Hi, so this chapter is about children with hematologic or immunologic dysfunction. The assessment of hematologic dysfunction includes looking at a CBC, reviewing historical data, and looking at physical assessment findings that kind of goes along with looking at historical data, except we're looking at what's going on right at this particular time. So we're going to be asking parents to describe incidents that will give us more information when we're looking at the historical data. We also look at the child's energy and activity levels and their growth patterns. Anemia is the most common hematologic disorder of childhood and really probably in adults as well. It is the decrease in the number of red blood cells and or a hemoglobin concentration that is below normal. When we have this, we have diminished oxygen carrying capacity of the blood. When you don't have as many red cells, you can't carry as much oxygen. So then we have a mild hypoxic event going on. It's classified using two basic approaches, etiology or physiology, and this is by looking at why is it that the erythrocyte or the hemoglobin is being depleted. Or we look at morphology, and morphology has to do with the changes that we can see microscopically in the red blood cell size, its shape, or its color. So we look at this little schematic that's in your book, and you can see that it talks about how we may have pallor and tachycardia, headaches, fatigue, those kinds of things, and they're associated with nutritional deficiencies or bone marrow failures. When we have increased red blood cell loss, we also see pallor, fatigue, headache, muscle weakness that can be related to the acute blood loss, which could be caused by nosebleeds or hemophilia. And then if we have increased RBC destruction, we may see jaundice or pallor, fatigue, tachycardia again, dark colored urine because the bilirubin that's being produced by the increased destruction of the red blood cells causes the urine to be a darker color. And so with that, we may have intracorpuscle, so in other words, we may have thalassemias, or we may have the extracorpuscular, which would be immunologic things or drug or toxic substances that are causing it. When we look at the consequences of anemia, what we get is a decrease in oxygen carrying capacity of the blood, and that leads to decreased amounts of oxygen available to the tissues, like I was saying, a hypoxic issue. And so we would see cyanosis, which results from the increased quantity of deoxygenated hemoglobin in the arterial blood. Doesn't tend to be as evidence, but we do get things like growth retardation that results from decreased cellular metabolism. If we don't have enough oxygen, the cells aren't able to metabolize as well, or we may have a coexisting anorexia that goes along with chronic severe anemia. And so we may see delayed sexual maturation in an older child as well as growth delay in a younger child. In general, when anemia develops slowly, the child's able to adapt, and so we don't see the massive changes. We don't see the tiredness and some of those kinds of things because the child just chooses not to be as active as they might have been if they weren't anemic. The effects of anemia on circulatory system is things like hemodilution. So we still need the same volume, so the body replaces the volume that would have been taken by the red cells and puts more plasma volume there. We may see decreased peripheral resistance, increased cardiac circulation and turbulence. So with that turbulence, remember, we end up with murmurs. And the increased cardiac circulation may lead to cardiac failure. We may see cyanosis, especially if it happens early on, and we'll see growth delay, which is kind of what we were talking about in the last slide. Diagnostically, what we see is we look at their history and physical. Is there a reason why this child is anemic? Do they have a condition that's causing them to lose blood, or do they have a condition that's causing them not to make new red blood cells? Or are they just not getting good enough nutrition so that they aren't making the red blood cells as they should? We look at the CBC, and what we see on the CBC with someone with anemia is decreased red blood cells. We see decreased hemoglobin, and we see decreased hematocrit. Remember, hematocrit is a percentage. It's looking at the percentage of red blood cells compared to the total percentage of blood volume. And so when we see the hematocrit decreasing, we see that the percentage of red blood cells are also decreased compared to the total blood volume. Typically, the hemoglobin is less than 10 or 11 in children with anemia. When we look at hematocrits, we're looking at hematocrits that are less than 30. Often I've seen hematocrits go down into the 20s, and in some cases into the low 20s. In infants particularly, and we'll talk a little more about this in a minute, when they get to their nadir, which is in the low 20s, that's when their body kicks in and starts producing more red blood cells. But prior to that point, their erythropoiesis doesn't happen because they aren't low enough for it to happen. That typically only happens in young infants. We see that nadir go down to that level around age 6 months. And so usually by that point in time, they're eating foods that are higher in iron, and so that brings them up because it's an iron deficiency anemia at that point. Other tests can be determined, the particular type of anemia. We can actually look at ferritin levels to find out if it's iron or other levels to see what it might be associated with. The therapeutic management of anemia is to treat the underlying cause. So if they had a hemorrhage, then they may need to have a transfusion. Or if they are symptomatic of their anemia, in other words, they have tachycardia and they're hypoxic and needing oxygen, they may go ahead and give them a transfusion to get that hemoglobin levels up. Now, the problem is that if there's an underlying cause, if you don't treat the underlying cause, then that hematocrit or that hemoglobin may drop right back down again, and then you're back where you started out again. Nutritional intervention is necessary for deficiency anemia, so we may have a need for B12, or we may need more iron. Supportive care is to have IV fluids to replace intravascular volume on somebody who may have hemorrhaged, receipt of oxygen if they are hypoxic and showing signs of cyanosis, bed rest because they are just so exhausted. Now, these would be the kids that are severely anemic, and diet changes to increase the amount of iron in the diet, or B12 are the primary ones that we would see. Also, family education to make sure that the family understands how to provide the best diet and how to care for the child if there's other issues going on. As far as nursing considerations, it's important to prepare the child and the family for the laboratory tests. This has a lot to do with the fact that uh, the child may have to have multiple blood draws over several times during the day, or perhaps even several days of several times a day blood draws. And so explaining to the child and the family why we're doing them so often will help them not to feel like we're constantly in there poking their child. Also, we have to make sure that we understand, or that they understand, that we may have to get things like stool examinations to find out if there's occult blood, so that that would show that there's intestinal bleeding. And so we have to look at some of those kinds of things and explain why we're doing it. When it comes to things like drawing blood, we can put EMLA cream at the site because that will help to prevent some of the pain that is associated with a blood draw. But remember, EMLA has lidocaine in it, and that will cause constriction of the blood vessels. So it does make the kid a harder blood draw when you do that. Explaining the significance, that's kind of what we've talked about before, and encouraging them to be with the child during the procedures and allowing the child to play with equipment on a doll, or to actually help to participate in some of the actual procedures is also helpful in dealing with the family and the child. We can decrease oxygen demands by making sure that we provide rest for the child, and that we don't do things that cause the child to burn up oxygen unnecessarily. Some of the signs of exertion include tachycardia and palpitations, tachypnea and dyspnea and shortness of breath. They may be dizzy, they may have a lightheadedness, we may see diaphoresis or change in colors. So if we see something like that, we want to encourage them to rest. Children with anemia are prone to infections, and that's one of the major complications that are associated with anemia. And they're associated with the infection is because when there's decreased tissue perfusion and oxygenation, it causes cellular dysfunction, and that weakens the body's immunity against infectious agents. And so we need to make sure as nurses that we're observing for signs and symptoms of infection, particularly temperature elevation. One thing that they mentioned in your book was looking for leukocytosis. However, an elevated white blood count in kids that happens as a result of anemia is not all that uncommon without any infection being present. And of course, we need to support and educate the family as we're dealing with them. When we look at iron deficiency anemia, it's caused by inadequate supplies of dietary iron. And generally, this is preventable. It's predictable at certain developmental periods. For instance, in premature infants, because they had a low fetal supply of oxygen before they were born, they tend to become anemic much sooner than the average full-term baby. So like I was telling you, full-term babies have a tendency to become anemic around 6 months, and that's because their fetal stores of oxygen are starting to be replaced, and they haven't completely gotten into adult hemoglobin yet. What we see with premature infants is that they tend to hit that nadir at a much earlier time, at about 1 to 2 months of age. And so we start seeing them not eating quite as well, not being quite as active. They may have signs of apnea, and usually with premature babies, if they have apnea, they have bradycardia as well, although we don't usually consider the bradycardia to be a sign of their anemia. And so, and they start looking pale. And so this is what happens with normal changes between fetal hemoglobin and adult hemoglobin. And like I was telling you, usually with an older child or a term child, we have the child is on iron-rich food, and the iron in their formula or in their breast milk is usually sufficient to help them get past this normal decrease in the nadir and then the development of erythropoiesis that would naturally occur at that age. And so we usually don't see any signs or symptoms in that term baby. Sometimes what we do with the premature babies is we'll give them erythropoietin, and that will help them to start producing their own red blood cells earlier, and so they don't tend to get as low of a nadir naturally, and we start giving them iron supplementation as well. At about 12 to 36 months, it tends to happen because that's when people take their kids off of formula and start giving them regular cow's milk from the refrigerator like everybody else drinks, that's not supplemented with iron. And so with that cow's milk in their diet, and these kids will have a tendency to drink more milk than they will later on in their lives. That will tend to decrease their hemoglobin. The other thing that we have to look at too is whether they're giving them too dilute of, like, skim milk really isn't good for kids either because it has even less nutrition in it. But that has more to do with protein issues than the iron issues. The other thing that happens as they start to do that is that the cow's milk will actually cause microscopic bleeding in the GI system, and that will actually make the anemia even worse. And so it's another reason why this is an issue at that age. In adolescence, we see the iron deficiency anemia hitting due to rapid growth and just generally poor eating habits because they want to eat like all of their friends and aren't eating the healthiest things. As far as therapeutic management in infants, if they're receiving iron-fortified formula and iron-fortified cereal, they usually do pretty well. If they're less than 12 months of age, they should not be given fresh cow's milk, and what we're talking about is the variety that we buy in the grocery store, because that can increase the risk of the GI bleeding. In older children, if the family eats iron-fortified food, it may be enough to take care of the anemia, so they're eating plenty of greens and iron-fortified breads and things like that. They shouldn't have any problem. But if they do have it, then we would give them iron fortification, either iron drops, or we would give them vitamins with iron. Now, as far as dietary changes versus getting supplements, it's always better if we can give kids their vitamins through the food that they eat rather than having to give them supplements. The body tends to tolerate them much better. But if they are not receiving enough iron in their diet, then supplementation is the next best thing that we should do. As far as prognosis is concerned, usually if they follow the plan, as far as changing diet or adding the supplements, usually there's no sequelae to them having had this period of anemia. Some of the nursing considerations and teachings that we need to do is that it's better to give the liquid iron supplement in 2 doses instead of 1 big dose. Usually we want to give it on a relatively empty stomach because iron binds with substances in milk, and so we should try to avoid dairy products when we're giving iron supplements. Now that makes it kind of hard with some of our babies because if we give them the iron on an empty stomach, they tend to barf it up. And so when that happens, we need to give it diluted, and what we dilute it in is formula, and so in a way it doesn't work quite as well. But yet any kind of increase in the iron is better than none, and so we do tend to do that with babies. So don't be surprised if you see something like that in the hospital. Iron supplementation does cause stools to turn dark green or almost a black color. Don't get that confused with meconium. Meconium has kind of the same color, but it has a different consistency than the stools that have turned dark due to iron. The iron, especially the liquid form, can stain the teeth temporarily. So on an older child, if you're giving them the liquid iron, then it's best if they drink it with a straw so that it gets past their front teeth, and have them brush their teeth after they've received it, and that will help to decrease the amount of staining to their teeth. You want to instruct the parents not to have any more than 1 month's supply on hand. That will help to prevent overdose and to make sure that they keep it outside of the child's reach. Honestly, this stuff tastes so nasty. I don't know why any kid would just drink down iron. But then again, kids have a tendency to do really stupid things. If we're giving iron as an IM injection, it needs to be given very deep into the muscle, and then we need to carefully observe for any signs of anaphylaxis after it's given. Sickle cell anemia is a hereditary hemoglobinopathy. It primarily occurs in African Americans and occurs in about 1 in 375 infants born in the United States. 1 in 12 has sickle cell trait. So sickle cell anemia itself, or sickle cell disease, which there is a difference between the two of them, is the group that is 1 in 375 infants. This is the child who actually has the disease. The 1 in 12 that has traits means that they can pass it on to their child, but they themselves don't have it. Occasionally, we also see it in persons of Mediterranean descent. It also is seen in persons of South American, Arabian, and East Indian descent as well. What we find with sickle cell is that it's common in areas of the world where malaria is also common, and individuals with sickle cell trait tend to have a survival advantage over those who don't have that trait. So the sickling of the cell helps them not to get the hemolytic response from the malaria, which is why they tend to do a little bit better with it. It is an autosomal recessive disorder. 1 in 12 African Americans is a carrier, meaning that they have the trait. And if both parents have the trait, each child of theirs will have a 1 in 4 likelihood of having the disease. The pathophysiology is that there becomes a partial or complete replacement of normal hemoglobin with abnormal hemoglobin S, which is the sickling. And the hemoglobin in the RBCs takes on an elongated or sickle shape. The sickle cells themselves are more rigid and they obstruct the capillary blood flow, especially now 1 or 2 of them sitting there in a bunch because they have it all the time, but during a sickle cell crisis, those sickled cells increase. So it's not that they're constantly having this obstruction of capillary blood flow, but the potential for it is there at all times because these sickled cells don't pass through the capillaries as well as the normal rounded shape of the RBCs. What we can see, though, is that they get microscopic obstructions that lead to engorgement and tissue ischemia. And this can happen at any time. If you think about it, if one cell gets stuck and then another cell comes along and it sticks to the one that's already stuck there, slowly but surely you're going to build up a dam, like a beaver dam, and the blood won't get past there, and so the area past that vessel is not going to get oxygenated blood. In addition, the sickle cells don't carry oxygen as effectively as a normal cell, so it also leads to hypoxia, which causes the sickling, and that leads to pain in the areas that are becoming hypoxic. We can get large tissue infarctions if they're blocked too much, and the damaged tissues in the organs can happen, which will lead to impaired functioning of those organs. So in other words, every time we get a blockage isn't going to necessarily happen out in the fingers or out in the legs, although it does happen in those places. It can happen anywhere in the body. So it can happen in the brain, it can happen in the organs, it can happen in the muscles, it can happen in the joints, it can happen anywhere in the body. One of the things that we do see is what they call splenic sequestration. And what happens with that is the whole design of the spleen is to filter out the broken and dysfunctional blood cells as they circulate through the spleen. Well, here are these sickled cells, which obviously are dysfunctional, and so the spleen starts filtering them out, and so the spleen gets filled up with these dysfunctional blood cells. And so what can happen is that they get an enlarged spleen, and it may require a splenectomy at an early age, and that results in an immunity issue. This picture in the book, I wasn't real thrilled with the drawing itself, but it does show you the specific organs that tend to be more affected by sickle cell anemia. Just kind of review this picture just to remind you if you have questions about why it would affect some of these organs more than others and you can't figure that out by thinking about the normal anatomy and what the blockage would cause, problems that the blockage would cause, send me out an email and I will be happy to talk to you about it, or when I get back in town on Tuesday, I will be happy to talk to you about it then as well. The prognosis for sickle cell anemia is that there is no cure because it is a genetic disorder. They have looked at possible bone marrow transplants for treatment, but that's not showing anything right now. Supportive care is very important, and so prevention of sickling episodes is very important. Uh, Frequent bacterial infections may occur due to their immunocompromise, and whenever there's an infection, that increases the sickling event. Um, Bacterial infection is the leading cause of death in young children with sickle cell disease, and they have strokes in 5 to 10% of the children with the disease, which results in neurodevelopmental delay and cognitive impairment. Again, basically, they're getting little strokes. I mentioned sickle cell crisis just a minute ago, and the precipitating factors for sickle cell crisis is anything that increases the body's needs for oxygen or alters the transportation of oxygen. Also, trauma, fever, infection, physical and emotional stress, increased blood viscosity due to dehydration, and hypoxia, like from flying at high altitude or being in high altitudes or being in poorly pressurized airplanes, anything that may cause hypoventilation, vasoconstriction due to hypothermia. So what happens with it is that you get acute exacerbations that vary in severity and frequency. And there's several different types. One is the vaso-occlusive thrombotic type, and it's the most common type of crisis. It's an extremely painful event for these kids, and in addition to needing to treat their sickle cell crisis, you also have to treat the pain that they're experiencing. And what we get is stasis of the blood with clumping of the cells in the microcirculation, and that leads to ischemia, and that leads to infarction. And the signs of this are fever, pain, and tissue engorgement. When you look at their joints, especially, you will see just a lot of swelling. They don't want you to touch their hands, things like that, because it's so painful in the areas that are affected. Splenic sequestration is a life-threatening type, and death can occur within hours if something isn't done quickly. And what happens with that is the blood begins to pool in the spleen, and the signs are profound anemia, hypovolemia, and shock. With aplastic crisis, you have diminished production and increased destruction of RBCs, and it's triggered by things like viral infections or depletions of folic acid. And so the signs for those include profound anemia and pallor. So how do we diagnose it? Well, if we know that there is sickle cell trait that's already in the family, then we do send cord blood in the newborn to make a definitive diagnosis for that particular child. We also screen for sickle cell anemia in the newborn screening tests that we do on all infants that are born in the hospital. And for that matter, even kids that are born at home, when they go to their pediatrician's office, also get the genetic testing done, or the not so much genetic testing, but metabolic testing done. Genetic testing is done to identify carriers and the children who have the disease within the family. They can also do a sickle turbidity test, and it's a quick screening for children that are over 6 months of age. And then hemoglobin electrophoresis is a very specific test that looks for sickle cell. The medical management for kids with sickle cell anemia, of course, the goals are to prevent the sickling phenomena and then to treat their medical emergencies. It's important for them to get their childhood vaccines, because if they were to get the disease, it increases the risk of them going to sickle cell crisis. We also aggressively treat any infection that they get, so that also will prevent them from getting as sick. And then because their immunity is affected as well, we often will give them prophylactic antibiotics from age 2 months to 5 years of age. We're going to monitor their reticulocyte count regularly to evaluate their bone marrow function. So if you think about it, your reticulocyte count is how we determine whether or not you're making new red blood cells or not. And so with this, because it's a form of anemia, you would have an increased reticulocyte count if you were anemic from the sickle cell anemia. We also give blood transfusions or exchange transfusions because that will reduce the ischemia. But of course, blood transfusions have their own risks that we've talked a little bit about before. So basically what's happening with the blood transfusion is that we are not so much replacing the sickle cells, but we are causing the volume of blood to have more of the normal red blood cells in it and not as many of the sickle cells, so we're kind of diluting out their effect. We talked a little bit before about exchange transfusions, or if you're listening to this one first before you listen to chapter 25, I talk a little bit more about exchange transfusions with that. But with an exchange transfusion, we take off some of the blood, so we draw out some of the blood and then we replace it with normal blood. So over a several hour period of time, we take off more of the blood that is the sickled cells, and then the child is able to have more of the normal cells that they've had replaced with the transfusion. And I probably said that in a very confusing way just now. But basically the idea is that we will take off a small amount of their blood, then we replace that same amount of volume through another site. And over a period of time, usually a couple hours, we are able to decrease the amount of abnormal cells and increase the amount of normal cells by giving them normal cells through the transfusion. Diet and nutrition is especially important for them. There are medications, especially pain meds, that are helping them to deal with the pain that they're dealing with. And in some cases, they may need to have a splenectomy, especially if they are having the splenic sequestrations. We need to monitor the child's growth and watch for failure to thrive because, again, when you're hypoxic, you don't tend to grow as well. We need to carefully do a multi-system assessment and assess and treat pain. We need to observe for the presence of inflammation or possible infection, as that can make this sickling worse. We need to carefully monitor for signs of shock and promote growth and development. There's a lot of psychosocial needs. Again, if you think about any child that has a chronic disorder, and sickle cell falls in that group of disorders, there's going to be psychosocial needs. Coping mechanisms and the development of them are going to be especially important because these kids have pain and they aren't able to do everything that their friends do because there's so many things that can precipitate them going into sickle cell crisis. We need to give support with genetic counseling so that other family, even if it's a brother or a sister of this child, that they are aware that they have the trait so that as they're having their own children, they understand that they may be passing this on to future generations. There's a lot of financial needs involved with this because of all the blood transfusions and frequent hospitalizations that these kids have to go through. Obviously, caregiver role strain is something that is a very real issue because really there has to be somebody within the family that's able to take off work and deal with the crises that these kids have from time to time. And then living with chronic illness in the family is always a stress and a strain for them as well. Thalassemia, there's two types of thalassemia. There's alpha thalassemia, where the A chains are affected. That the alpha thalassemia tends to occur in Chinese, Thai, African, and Mediterranean people. And then there's beta thalassemia that occurs in Greeks, Italians, and Syrians. The beta type is more common, and it has 4 different forms. The Cooley anemia is one of inherited blood disorders of hemoglobin synthesis, and it's classified by hemoglobin chain affected by the amount of effect. It's an autosomal recessive disorder with varying expressivity. Both parents must be carriers in order to have an offspring that has the disease. The 4 types, there's thalassemia minor, which is asymptomatic, is the asymptomatic silent carrier. The thalassemia trait, they have a mild microcytic anemia, and thalassemia intermediate, they have moderate to severe anemia plus splenomegaly, and thalassemia major, which is the Cooley anemia, is severe anemia requiring transfusions for survival. The pathophysiology of thalassemia is that the anemia results from defective synthesis of hemoglobin and structurally impaired RBCs, also a shortened life of the RBCs. So as a result, they have chronic hypoxia that demonstrates as headache, irritability, precordial and bone pain, exercise intolerance, anorexia, and nosebleeds. It's usually detected in infancy or toddlerhood because they have pallor and failure to thrive. They also have hepatosplenomegaly and severe anemia. Often their hemoglobin is less than 6 grams per deciliter. They diagnose it through CBC results, which shows the anemia, and then they do the hemoglobin electrophoresis, and that confirms the diagnosis. Sometimes they'll look at x-rays because they're ruling out other causes, and usually we start seeing RBC changes as early as 6 weeks of age. So if we know that both of the parents are carriers, then they're going to be watching this kid more closely for signs of having the disorder. So history and physical examination combinations are very important in looking at this disorder. Usually what you'll hear the doctors ask is there anybody in your family that has these symptoms or had this disorder? And that's usually how they start determining that this is an inherited disorder, and then they do additional blood work for it. The medical management consists of blood transfusions to maintain normal hemoglobin levels, but the side effect is something known as hemosiderosis. And basically what that means is the red blood cells that the child is making themselves are dying sooner, so they're getting destroyed, and then we're giving more red blood cells, and transfused red blood cells don't live as long as the ones that we normally produce ourselves because they're already been taken out of somebody's body, and they're at varying stages of their life cycle. And so what happens is we have increased breakdown of these red blood cells. When we have increased breakdown of the red blood cells, we have increased iron levels in the body. And so what we have to do is give iron chelating drugs, which are drugs that the iron binds to so that it can be expelled from the body. And one of the drugs that we give to do that is deferoxamine or desferol, and it binds the excess iron for excretion by the kidney. So this is one of those words that is a good word to learn, is this word chelating, because chelating is the idea of a drug that causes something that's not supposed to be in the body to be excreted from it. So we have, in this case, we have iron chelating drugs, but we also have chelating drugs like for increased mercury or increased lead as well. So that's one of those new words for you guys to learn. As far as the prognosis, we often see delayed growth, so a little shorter than what we would expect kids to be, delayed or absent secondary sex characteristics that goes along with the delayed growth. They do expect to live well into adulthood with proper clinical management. And of course, that means that they will continue to get that management in adulthood. And they're looking at bone marrow transplant as a potential cure for this. When we look at the nursing management, we want to observe for complications related to their transfusions. We want to provide emotional support to the family, promote compliance with the treatment, because obviously this is kind of a pain to be getting transfusions all the time and being on these special medications as well. We want to foster adjustments to having a chronic disorder. This is something that we just say, you know, this is just part of who you are. We can't say it's good, it's bad, it's just part of who you are. And we want to encourage genetic counseling for the family so that they know who is a carrier and who's not, and provide education for the patient and the family on self-care. Aplastic anemia, AA, is when all formed elements of the blood are simultaneously depressed. We call it pancytopenia. In hypoplastic anemia, there is profound depression of the RBCs, but normal levels of white blood cells and platelets. So, two different forms. The etiology is idiopathic. In other words, we really don't know why, but there is some genetic congenital autosomal recessive traits in some cases, or it can be acquired so that you get severe or moderate symptoms. As far as the diagnostic evaluation, again, it's important to get a history and physical examination results, and they will do blood and bone marrow examination. The therapeutic management is usually transfusions in this case, and follow-up care. And of course, we have the same kinds of nursing considerations as we have with the other types of anemias. And with these, we, especially with the pancytopenia, we worry about infection and clotting disorders. Hemophilia is a group of hereditary bleeding disorders that result from deficiencies of specific clotting factors. Typically, it's an X-linked recessive pattern, which means that it's primarily males that are affected, although there are forms of hemophilia where girls are also affected. And so it's inherited through the maternal side of the family. Hemophilia A is classic hemophilia with a deficiency of factor VIII, and it accounts for 80% of the cases of hemophilia. Hemophilia B is also known as Christmas disease, and it's a deficiency of factor IX. Von Willebrand disease is a deficiency in abnormality or absence of von Willebrand factor and factor 8. And that disease affects both males and females. The etiology of hemophilia A is it's an X-linked recessive trait. Males are affected, but females may be carriers. And the degree of bleeding depends on the amount of clotting factor present and the severity of the given injury. Up to 1/3 of cases have no known family history, and in these cases, the disease is caused by a new mutation. The manifestation of hemophilia is we have bleeding tendencies that range from mild to severe, and the symptoms may not occur until the child is 6 months of age. Heme arthrosis is one of the major disability-causing portions of hemophilia, in that they get bleeding into their joint spaces, especially of the knee, the ankle, or the elbow, and that leads to impaired mobility, and eventually it leads to bony changes and disability. The symptoms of that include warmth, pain, bruising, and decreased movement, just like we would expect with bleeding into a joint. Manifestations of hemophilia include nosebleeds, bleeding in the GI tract, excessive bleeding after procedures, even minor trauma, tooth extraction, minor surgeries. And when you think about tooth extractions, don't think so much about going to the dentist for tooth extractions, but think about how kids lose their teeth naturally, and there's a little bit of bleeding that happens with them. Well, it would have an excessive amount with their loss of their baby teeth. Large subcutaneous and intramuscular hemorrhages may occur. They may have bleeding into the neck, the chest, or mouth that can compromise the airway. They can also have bleeding in the spinal cord that can cause paralysis. The diagnostic evaluation can be done through amniocentesis in somebody that knows that they are a carrier. Genetic testing of family members is needed to identify who the carriers are, and the diagnosis is made on the basis of the history, laboratory studies, and the examination. The laboratory tests will show low levels of factor 8 or 9 and a prolonged partial thromboplastin time, or PTT. So remember, with PTT, we don't want it to last a long time. We want it to be short. The platelet count, prothrombin time, and fibrinogen levels will all be normal, because there's nothing wrong with those cells. It's the lack of those factors that lead to the next step in the clotting cascade. Finally, the medical management is replacement of missing clotting factors. So these kids get pooled blood products that give them their factor 8 or factor 9. This was one of the reasons why kids were exposed to HIV when HIV started to be seen here in the US, because with the pooled product, you could have 100 different people in this one pooled product, and if one of them had HIV, it would cause an infection. So another thing that they give is desmopressin, or DDAVP. It's given IV, and it increases factor 8 activity by 2 to 4 times, and that's used for mild hemophilia. Transfusions can be given, and prompt intervention to reduce complications for the bleeding that's happening right at that particular time. And then medications for pain and anti-inflammatories are also used to some degree, and exercise and physical therapy to work on the decreased mobility that they have in their joints. As far as the prognosis, Historically, most patients died by age 5. Currently, patients with mild to moderate hemophilia live nearly normal lives, and gene therapy is one thing that they're looking at for future cures. Infused carrier organisms act on target cells to promote manufacture of the deficient clotting factor. What I can tell you is that I had a friend who was a carrier for hemophilia. She had 2 boys, both of them had hemophilia, and they both died around the age of 10 or 12. And it's just one of those really sad things. Strokes are increased with them, again, because of the bleeding into the brain. And really, those were the causes of deaths previously and continue to be with those that have moderate to severe hemophilia. We sit here currently, if they have mild to moderate, they live normal lives. But they don't mention that if you have moderate to severe hemophilia, it's still a cause of early death in children. As far as nursing care management, we want to prevent bleeding episodes. So these kids are, they aren't going out and doing contact sports. We want to recognize and control bleeding, support the patient as far as pain and mobility, and promoting growth and development. We want to support the family with education and help them to prepare for home care. Some of the interventions, close supervision in a safe environment. Dental procedures are done in a controlled situation. When they get old enough to shave, they're shaving with an electric razor and not with blades. And for superficial bleeding, apply pressure for at least 15 minutes. Normally we say, 30 seconds, 3-4 minutes, basically until the bleeding stops. Well, it may take longer for their bleeding to stop. And applying ice to promote vasoconstriction to help the clotting. If significant bleeding occurs, they need to get a transfusion for their factor replacement. One of the things that we really have to think about these kids is if a child has hemophilia and should have a head injury, that's a major event for them. And so that's definitely high priority, and they need to be seen in a medical facility. As far as managing the hemarthrosis during bleeding episodes, elevate the joint and immobilize it, apply ice, give the child analgesia. Range of motion exercises after the bleeding stops will help prevent contractures. Continued physical therapy to prevent the contractures are going to be very important. And definitely these kids need to avoid obesity to minimize their joint stress. Idiopathic thrombocytopenia purpura, or ITP, is an acquired hemorrhagic disorder that's characterized by thrombocytopenia, which is excessive destruction of the platelets, or I guess I should say is a result of excessive destruction of the platelets. Thrombocytopenia in and of itself is just a decreased level of platelets. Purpura is the discoloration that's caused by petechiae beneath the skin with no other signs of bleeding. These kids have normal blood marrow. It occurs in 2 different forms. The acute, which would be is self-limiting, and it usually follows a viral illness. The chronic version is the thrombocytopenia that lasts longer than 12 months. The diagnostic evaluation consists of looking at the platelet count, and we would find that the platelets are less than 20,200 per millimeter. And then we have to rule out other diseases and conditions to show that they have the idiopathic thrombocytopenia purpura. The therapeutic management looks at avoiding injury and may include transfusions of platelets. The prognosis is actually pretty good on these kids, and we look for, as far as nursing considerations, avoiding injuries that may need to have platelets in order to stop the bleeding. Kind of the same things that we look at when we're looking at hemophilia, except in this case, it's the platelets that are causing problems. We're going to be watching them closely as they're being transfused, and also making sure that the family is aware of how to protect their child from injuries. With disseminated intravascular coagulation, or we also call this DIC, what it is a consumption coagulopathy. It's a disorder of coagulation that occurs as a complication of numerous pathologic processes or triggers like hypoxia, acidosis, shock, and endothelial damage. So basically what happens is the body consumes the platelets and the clotting factors so that this person is not clotting well, and then it turns around and rebounds. So we'll talk a little bit more about that. The pathophysiology is that the coagulation process is abnormally stimulated, and there's two distinct phases. First, we have excessive amounts of thrombin that's generated, and then after that, so we get a lot of little microclots, and then we get a fibrolytic mechanisms activated that cause extensive destruction of the clotting factors. So first we have too much clotting, then we have not enough. And so they start bleeding from all sites where they've had IVs or blood draws. The diagnostic evaluation, obviously we look at the physical examination findings, and what we see on CBC or on clotting labs is that we have prolonged coagulation. The therapeutic management is to treat the underlying cause and support the patient as best we can. Nursing considerations, often they have nosebleeds, often they will have bleeding all over the place, and so treating the patient and the family and explaining what's going on to them is very important, and providing whatever type of support is necessary. Often these people with DIC are very, very ill, and because it is associated with infection, and so we end up, these kids are often in the ICU and can possibly be on pressor support as well because of the change of clotting. Then when we look at immunologic deficiency or disorders, we primarily think of HIV and acquired immunodeficiency syndrome, or AIDS. As far as epidemiology, currently the principal modes of HIV transmission to the pediatric population are mother-to-child transmission and adolescent risky behaviors like sexual activity or IV drug use. As far as the etiology and pathophysiology, HIV is a retrovirus that's transmitted by lymphocytes and monocytes. It's found in the blood, the semen, vaginal secretions, and breast milk. It has an incubation or latency period of months to years. So it's possible that somebody may have been exposed but will not show changes in their labs for years in some cases. There are different strains of HIV, whereas HIV-2 is prevalent in Africa. HIV-1 is the dominant strain in the United States and other parts of the world. Horizontal transmission of HIV occurs through intimate sexual contact or parental exposure to blood or body fluids containing visible blood. These are your needle sticks. These are people that are taking IV drugs. So horizontal means it's happening to people usually of same age, people that are having sex with someone else on that level. Perinatal or vertical transmission occurs when HIV-infected pregnant women pass the infections on to their infant. There's no evidence that casual contact between infected and uninfected individuals can spread the virus. So holding somebody's hand, giving them a hug, even kissing has not been shown to spread HIV, although we know that there is some HIV in saliva, but they've never been able to show that just kissing somebody caused an HIV infection. As far as the pathophysiology is concerned, the HIV virus primarily infects a specific subset of the T lymphocytes, the CD4 cells. But it can also invade cells of the monocyte macrophage lineage. The virus takes over the machinery of the CD4 lymphocyte and uses it to replicate itself and renders the CD4 cell dysfunctional. The lymphocyte count gradually decreases over time, and at some point they start getting physical symptoms. The count eventually reaches a critical level, and when that happens, then opportunistic illnesses occur, followed by death. And once the opportunistic illnesses start occurring, that's when they say that they have changed from being an HIV-infected individual to having AIDS. Some of the common clinical manifestations is lymphadenopathy, hepatosplenomegaly, oral candidiasis. Oral candidiasis is one of the opportunistic diseases. Although if it happens in an infant, we don't necessarily say that it's being caused because of their immune problem, because it could be that the family just isn't cleaning the bottles well enough. Chronic or recurrent diarrhea, failure to thrive, developmental delay, and peritonitis. We start seeing the defining conditions in children, which is really when you're starting to see AIDS, is when they have pneumocystis carinii, pneumonia or PCP, lymphoid interstitial pneumonitis or LIP, recurrent bacterial infections, wasting syndrome, which goes along with that chronic or recurrent diarrhea, candidal esophagitis. So there's a difference between having oral candidiasis, which is thrush, and having it spread into the esophagus, because once it starts spreading into the esophagus, then it makes it uncomfortable to eat. HIV encephalopathy, cytomegalovirus disease, Mycobacterium avium intracellular complex infection, pulmonary candidiasis, herpes simplex diseases, and cryptosporidiosis are all things that tell us this is really abnormal for a child to be having these things, and leads us to investigate further and show that they have HIV infection if they haven't already been diagnosed with it. And usually at that point, they don't just have HIV infection, but they have AIDS. So diagnostic tests, we cannot do the ELSA or Western blot immunoassay on children less than 18 months of age because it will test positive because they still have antibodies from their mother. And so they are not considered to be HIV positive until they're over the age of 18 months and have a positive ILSA or a Western blot immunoassay. We can do um, PCPs on kids earlier, and usually based on that or PCRs, I'm sorry, um, and that will identify the HIV infection at a much sooner time period, but it is not considered the gold standard, and so at this point in time they still need to have the ILSA and the Western blot immunoassay to say whether or not they have HIV infection or not. And either one of those tests can either say yes, they did get the infection from their mother, or no, they managed not to get it. And that's determined on what the mother's viral load was looking like during the pregnancy. If mom's viral load was very low, the chances of the baby getting it are greatly decreased. But if mom's viral load was high, it greatly increases the risk that the baby will have gotten HIV from the mother. As far as therapeutic management, they are put on antiretroviral drugs, and once we have a true diagnosis on them, they're put on HART, which is the highly active retroviral drug cocktail of more than one medication, so that we treat the HIV from a number of angles and not just on one angle. That helps to prevent the virus from becoming resistant to the medications that we have. We want to work to prevent opportunistic infections, and eventually, as the kid gets older, we have to talk about prevention of the spread of their infection to other people. And these kids become very compassionate and intelligent about their disease. It's really pretty amazing to watch them and listen to them. Severe combined immunodeficiency disease, or SCID, is the absence of both humoral and cell-mediated immunity. Is genetically acquired. The diagnosis is done through looking at DNA as well as looking at their lab values. The therapeutic management involves blood transfusions and isolating the children to protect them from getting infection. And it's just these are the kids that are the kids in the bubble, that any kind of exposure to infection is going to make them very, very ill. And I'm not going to spend a lot of time talking about it because it is very, very rare, but just something that you should know about. As far as technologic management of hematologic and immune disorders, blood transfusions are used very frequently, whether it's packed red blood cells or platelets or pooled factor VIII, it's still a blood product. With the pooled factor VIII, it's not type and crossed and things like that, like other blood products, so it's a little different on them. But we talked in the other lecture in chapter 25, I talked a little bit about some of the things that you have to look for with blood transfusions, but this is more the basics. And so we want to verify the identity of the recipients and the donor's blood group. There's nothing worse than if we give the wrong blood type to somebody. So we want to make sure that everything matches, and it's not like the people in the blood bank can't make mistakes. And I want to say that at least one time in my nursing career, we did see something where it said donor's type is whatever it was, and the recipient's blood type was not compatible with the donor's type. And we had to send the blood back to the blood bank and have them retype, not retype, but recross match the blood. We want to monitor vital signs often during transfusion. We get an initial baseline before we start the transfusion, and then 15 minutes after initiation and 15 minutes after completion. And usually we check vital signs every 15 minutes throughout the transfusion. We want to use an appropriate filter, and we have a saline flush that's attached. Basically, this tubing is sort of a V-type shaped tubing with the blood hanging on one side of the tubing and the saline on the other. The flush allows us to have something to infuse if we need to stop the blood transfusion. We want to use the blood within 30 minutes of arrival. That doesn't mean that we use it all, but we want to start the transfusion within 30 minutes of when it gets to the unit. We don't want it just sitting up there. And we want to infuse a full unit over 4 hours maximum. If for some reason a child or an adult cannot tolerate the volume that is needed to be given in their blood transfusion, and the doctor orders it to be given over a longer period than 4 hours, what we do is we ask the blood bank to split the blood that's going to be transfused. So we get an amount that will go over the 4 hours, and we have them keep the additional blood in the blood bank so that we can get that blood and infuse it in for the additional amount of time, so that we don't have it hanging more than 4 hours. We need to be alert to reactions, and if a reaction occurs, we need to stop the transfusion immediately. When we stop the transfusion of the blood, we start the infusion of saline so that we don't lose the IV site, because we may need it for medications if they have an anaphylactic reaction to the blood. So that concludes this lecture, and includes this is the last lecture for this course. So I look forward to seeing you in a couple days, and y'all, if you have any questions at all, please feel free to contact me, and I'll see you guys soon.